Hello there, this is Dr. Mike Griffiths, and I'd like to thank you all for joining the lecture by Professor Frykberg on the approach of topical wound oxygen and wound healing, and specifically highlighting some of our unique cyclical pressure approach that delivers not only oxygen, but oxygen under a pressure delivery waveform that allows for deeper penetration, for the reduction in any local or interstitial edema, and for creating a pumping action on the wound to help with perfusion. I'm joined here also by Despi Herodotou. Hello, Despi.
Hi, how are you?
Good. And we're open for any questions. If any of you have any questions you would like to learn more or have anything that's been stimulated from the discussions by Professor Frykberg, feel free to ask them here.
Do you want to sort of elaborate on how we are actually a multimodality therapy, not just oxygen?
Yeah, I think that's a very important feature. The uniqueness of our approach is that we take oxygen and that we cycle oxygen in an extremity chamber around the limb, which creates cyclical pressure between 10 and 50 millibars. And that creates a very high diffusion gradient of about 800 millimeters of mercury for oxygen molecules to diffuse into the wounded tissue, which commonly has oxygen tensions in the single digits, and creates lots of oxygen to diffuse into that tissue, allowing us to supercharge and upregulate initially the body's immune function to take on any local burden, pathogens in the tissue, allowing us to come out of that inflammatory phase, and then moving on then into the proliferative phase where the oxygen feeds the fibroblasts to lay down good quality collagen and stimulates angiogenesis so that we heal with very patent tissue, but also with well perfused tissue and a stronger capillary bed. The pressure that we go to is very important, the 50 millibars, because that's the same pressure as utilized for a level-free compression dressing. So if there is any edema pressure, we create non-contact compression to reduce that edema down. And certainly even in wounds that aren't endematous by nature, you have interstitial edema. So by compressing and then relaxing the pressure, we create a pumping action that moves fluids around and helps distribute normal osmotic pressures between the arteries, the veins, and the lymphatic system. The third thing that we do that makes it multimodality is we add humidity. So if you have a dry wound, which many diabetic heel ulcers, etc., we add moisture to maintain a moist wound environment that we all know is critical to healing of any chronic wound.
So, but Mike, even though we add the humidity, the patients don't have to remove their dressings for this therapy, and it's done at home, correct?
That's a very, very important feature. So one of the approaches here is this is a home care therapy. It's adjunctive, obviously, to good standard wound care. And with the expansion in our product range to now a much larger version of the chamber, the patients can leave their dressings in place as long as they are gas permeable because the oxygen will diffuse through. And that's particularly important for patients with compression dressings or UNNA boots, or those if you're offloading with total contact casting. So again, it's a very unique approach. It's a multimodality that combines the benefit of a true home care therapy that has been proven to be particularly invaluable during COVID, where patients either are unable to due to their high risk of illness from COVID, or ill prepared to come into clinics. We can provide protective care and help trigger the healing process in their chronic wounds.
Mike, we do have a question, but quickly before you answer that question, could you quickly touch on, by adding more oxygen than we see in a healthy individual, so what happens to that enzymic activity when you do actually take the partial pressure of oxygen above 760 millimeters of mercury and potentially up to 800?
So that's very important. So when we supercharge oxygen or provide much higher partial pressure of oxygen as high as 800 millimeters of mercury to the wounded tissue, what we do is we provide the primary reason we know chronic wounds are stalled in the inflammatory phase is due to some antagonist that's causing an inflammatory response. Even in many cases where it may not be clinical infection and just colonization of bacteria, the low levels of oxygen in that wounded tissue, which quite commonly can be as low as 4 or 5 millimeters of mercury, mean the body's leukocytes and the neutrophils are unable to create the reactive oxygen species needed to create the hydrogen peroxide and take on that bacterial burden. When we take the partial pressure around the limb up to 800 millimeters of mercury, we diffuse lots of molecules into the wounded tissue because there's such a high gradient from 800, shall we say, to 5 or 6 maybe. The oxygen molecules migrate quickly into the wounded tissue, and they provide the fuel then for the leukocytes to do their upregulation and to provide adequate annihilation of the localized infection that might be there, even at low levels. So again, it upregulates the NADPH oxidase enzyme. The inflammatory mediators come down, the interleukins and the cytokines relax. Correspondingly, the growth factors of VEGF, the PGFs go high. You see a lot of angiogenesis and growth of new blood vessels. And now the fibroblasts start to migrate to the area to lay down collagen tissue. And there we provide the oxygen for the cytochrome oxidase and the processes needed to lay down good quality collagen tissue and the wounds fill in with good granulation tissue from the bottom up with a much more robust vascular bed feeding it. And what we've shown, as Dr. Frykberg mentioned in the study, is not only a 6-fold reduction, efficacy at healing at 12 weeks, so 6-fold more likely to heal chronic refractory diabetic foot ulcers at 12 weeks. But when we follow those patients out over 12 months in the same randomized trials, we showed a 6-fold reduction in reoccurrence at 12 months. So really durable healing. And the question that's been asked there is HBOT, full body hyperbaric, is commonly used and available. So when is this approach going to be more available? And currently the therapy is fully reimbursed and available through the Veterans Administration, for both VA clinics, for patients at home, but also for those being seen in the community care program. We're fully covered in New York State Medicaid, which covers about 7.5 million people. And then with the strengths of our latest RCT and ongoing health economic analysis, we expect to get broader coverage into other sectors as this year and next year progresses. Someone asked how the therapy can be delivered over dressings. As long as the dressings are gas permeable, which most dressings are, because you want the wounds to breathe naturally anyhow, then when we apply the oxygen therapy, the dressings can be less in place. And this makes it very easy for patients at home. If they're removing the dressings as part of their daily or regular care, then they can remove them as well. And the therapy is a therapy that's used 90 minutes a day. Our standard protocol is 5 days a week. The patients apply it whilst they're sitting there, usually watching television, and it's very easy for them to apply.
Mike, there's a quick question on VLUs. They're even more widespread than DFUs and more challenging to heal. Yes. Would you like to have we've got about 1.5 minutes left if you'd like to quickly.
Yes, so we have some really strong clinical trial data on VLUs as well as DFUs. And in those studies, they showed efficacy very similar to what we see in the DFUs, including looking at those wounds out over 3 years and showing only a 6% reoccurrence over 36 months or 3 years, compared to close to 50% in the control arm. So again, the same logic comes into play when those patients are treated. They leave their compression dressings, or if they're using UNNA boots in place, they're completely gas permeable. We do the therapy over them. It compresses the edema down. It stimulates with the oxygen. All the healing mechanisms need to take those wounds to complete healing. And again, what we show is much reduced reoccurrence due to the durability of healing that occurs.
Mike, can I just quickly also say on that study that there was MRSA elimination at week 5 in patients, in 46% of patients colonized with MRSA compared to 0 in the conventional compression dressings group. And then in addition, the pain score went from 8 to 3 in 13 days on those acutely painful wounds. So again, with VLUs, we've got some outstanding results.
So yes, a few other questions I just have pointed out. Our standard protocol for the therapy is 90 minutes a day, 5 days a week, but there are no contraindications to do the therapy more often. And certainly for wounds that have a lot of edema present, where the non-contact compression was our cyclical approach, has particular benefit, there clearly could be arguments for using the therapy, either daily, 7 days a week, or potentially we have a number of patients that use it multiple times a day to get very good healing on those wounds as well.
Is our therapy similar to or the same as other TO2? Go ahead.
Very good question. Topical oxygen therapy devices are not all the same. So they all deliver oxygen to wounded tissue, but the vast majority of them out there are what they call continuous diffusion devices that deliver very minute amounts of flow of oxygen continuously underneath the gas-occlusive dressing. Clearly, they've been shown in RCTs to have benefit, but predominantly in what tends to be University of Texas 1A, more superficial wounds. Our therapy is true multimodality, so it's not a monotherapy where we take oxygen and deliver it to much higher pressure, up to 50 millibars, which creates not only a higher gradient for the oxygen to diffuse, but the non-contact cyclical compression and the addition of humidity to maintain a moist wound environment. And what we've shown is we have efficacy both short and long term in more difficult wounds all the way to University of Texas to C and D, so infected and ischemic wounds penetrating all the way down to muscle and tissue, and venous ulcers that have been refractory for a minimum of 2 years in our venous study. So again, I think they both have a role. It's just slightly different areas.